Margaret was 71 years old when she died on a Wednesday morning while watering her garden. No chest clutching, no dramatic collapse like you see in films. She simply sat down on the grass, leaned against the fence, and never got up again. Her neighbor found her 40 minutes later, still holding the hose. What made Margaret's death different from the thousands of similar ones that happen every single week across this country was what the coroner found afterward. Her heart showed no significant blockages. Her arteries were reasonably clear for a woman her age. There was no obvious reason she should have died that morning. And yet she did, because sitting on her kitchen counter, lined up neatly beside her morning orange juice, were 5 prescription bottles, all filled within the previous 3 weeks, all prescribed by doctors she trusted completely. All medications that millions of Americans over 60 are taking right now, today, this moment, believing with absolute certainty that those pills are protecting them. What those pills were actually doing to Margaret's heart is what I'm going to tell you today. And I need you to stay with me because some of what I am about to share will make you question everything you have been told about the medications in your own medicine cabinet. I have been treating cardiac patients. I have sat in more difficult family conversations than I can count, trying to explain why someone who did everything right, took every pill, attended every appointment, still ended up on my table or in a coffin. After Margaret's case, I stopped accepting the standard explanations. I pulled research that most physicians never have time to read. I examined drug interaction data that pharmaceutical companies bury in the back pages of studies nobody looks at. And what I discovered changed the way I practice medicine permanently. Here is the terrifying reality that nobody in the healthcare system has a financial incentive to tell you. The medications prescribed most commonly to people over 60 were tested primarily on people under 55. The average age of participants in major cardiovascular drug trials is 52 years old. They are designing dosages and safety profiles for bodies that are biologically a decade and a half younger than yours. And then those same doses get handed to 70-year-olds whose livers process medications 30 to 40% more slowly, whose kidneys filter at reduced capacity, whose hearts have less reserve to absorb the chemical pressure those drugs create. You are not taking the same medication a 52-year-old takes. You are taking an overdose designed for someone else's body. There are 5 specific medication categories doing the most damage right now to people just like you. And the combination of them, which most elderly patients are unknowingly on, creates something that cardiologists call polypharmacy toxicity, a situation where individually manageable drugs combine into something your aging body simply cannot survive. Margaret was on all 5, and I am going to tell you exactly what they are, how each one is damaging your cardiovascular system right now, and what you can actually do about it. But before I do, I need you to understand one foundational truth about how your body has changed. After 60, your liver takes up to twice as long to process medications. Your kidneys, which should be clearing drug residue from your blood, are operating at perhaps 60 to 70% of their original capacity. And your heart, which has been beating without rest for 7 decades, has far less tolerance for chemical disruption than it once did. This means that a drug interaction that causes minor discomfort in a 45-year-old can cause cardiac arrest in a 72-year-old. Not because you are weak, because you are physiologically different, and the system prescribing your medications has never fully accounted for that difference. Right now, I want to ask you a genuine favor. If this information is something you have never heard from your own doctor, please hit the like button and subscribe to this channel. I make these videos because people like Margaret deserve better than what the standard system offers them. Subscribing costs you nothing, and it helps me reach more people who are sitting at home right now taking these exact medications without knowing what they are doing. Also, drop a comment below telling me either one, if you are currently taking multiple prescriptions and want more information like this, or 2, if someone in your family is on several medications and you are watching this on their behalf. And tell me where you are watching from and your age. That information helps me understand who needs this most. Now let us talk about the 5 medications. Medication 1, calcium channel blockers. This category includes drugs like amlodipine and diltiazem. They are prescribed to roughly half of all adults over 60 with elevated blood pressure, and doctors describe them as gentle, well-tolerated, and heart-safe. What doctors are less likely to explain is the compensatory mechanism these drugs trigger inside an aging cardiovascular system. When you force your arteries to relax artificially, Your body reads the resulting pressure drop as a crisis. It releases adrenaline. Your heart rate accelerates to compensate. For a 45-year-old with a strong, elastic heart, this reflex response is manageable. For a 72-year-old whose heart muscle has already lost significant reserve capacity, that constant artificial stimulation is quietly exhausting the muscle over months and years. I had a patient, a 74-year-old retired teacher named Gerald, who came to me with progressive ankle swelling and fatigue that 3 different doctors had dismissed as normal aging. When I reviewed his full medication history, he had been on 10 milligrams of amlodipine for nearly 4 years. His ankles were not swelling from age. They were swelling because his heart could no longer keep up with the compensatory demands the medication was placing on it. That swelling is your heart sending you a signal. And when those signals get labeled as acceptable side effects and ignored, the outcome becomes predictable. Keep watching. What I am about to share about the next medication may be the most important thing you hear today. Medication second. ACE inhibitors, lisinopril, enalapril, ramipril. These are prescribed as standard cardiovascular protection for most seniors with any history of blood pressure concerns. They are presented as kidney protective and routinely recommended as among the safest options available for long-term use. Here is what happens in an aging body that does not get discussed in a standard appointment. ACE inhibitors prevent your kidneys from eliminating potassium at the rate they normally would. In a younger person with healthy kidney function, the body compensates. But in someone over 65 whose kidneys are already clearing waste at reduced efficiency, potassium begins accumulating silently in the bloodstream. It builds gradually, producing no obvious symptoms, until it reaches a level that disrupts the electrical signals controlling your heartbeat. At that point, the disruption can be sudden and fatal. Margaret's autopsy revealed potassium levels that were clinically life-threatening. She had been on lisinopril for 3 years. Her doctors checked her potassium levels annually. The problem is that potassium accumulation in compromised kidneys does not announce itself with a gradual visible warning. It climbs quietly between appointments, and then it does not wait for your next scheduled blood draw to become dangerous. If you are on an ACE inhibitor and also using a salt substitute to reduce sodium, I need you to hear this clearly. Most commercial salt substitutes contain potassium chloride. That combination, a potassium-retaining medication plus a potassium-rich salt substitute, can create the exact scenario I just described. Margaret's dietitian had recommended a salt substitute to protect her heart. Nobody checked the label against her prescription. Medication third, statins. Atorvastatin, simvastatin, rosuvastatin. These are the most prescribed cardiovascular drugs in the world, and they are marketed with a confidence that borders on certainty. 73% of adults over 60 in this country take them daily, believing they are making a sound long-term investment in their longevity. Many of them are right, some of them are not. The mechanism I want you to understand has nothing to do with cholesterol. It has to do with a compound your heart cells use as fuel. Statins work by blocking an enzyme in the liver that reduces cholesterol production. That same enzyme is responsible for producing something called coenzyme Q10, which is the primary energy source for heart muscle cells. When you deplete it over months and years, you are not just lowering cholesterol, you are gradually reducing the energy available to the very muscle responsible for keeping you alive. Elderly individuals already have naturally lower coenzyme Q10 levels than younger adults. Adding a statin to that baseline can reduce levels by another 30 to 40% over time. In many patients, this creates a slow, progressive cardiac fatigue that presents as unexplained exhaustion, muscle weakness, and eventually heart failure that gets attributed to age rather than medication. The practical question is not whether statins have value, they do in specific circumstances, but whether the ongoing risk-benefit calculation for your particular age, kidney function, and full medication list has actually been reviewed recently. Margaret's statin dose had not been reassessed in 3 years, despite 2 new medications being added to her regimen in that period. Medication fourth, diabetes drugs, specifically thiazolide and nadiones. This category is the one most people have never heard discussed in a public health context, and that absence of awareness is part of what makes it so dangerous. Thiazolidinediones, sometimes called TZDs, work by improving insulin sensitivity and are prescribed to adults managing type 2 diabetes, which disproportionately affects people over 60. The concern specific to elderly patients involves fluid retention. TZDs cause the body to retain sodium and water at a level that, in a younger patient with a strong heart, remains manageable. In a senior with any degree of existing cardiac compromise, that retained fluid increases the workload on an already stressed heart. Studies examining this class of drugs, specifically in patients over 65, found measurably higher rates of congestive heart failure compared to other diabetes management approaches. What makes this particularly relevant to you if you are managing blood sugar with medication is the combination effect. A patient on a TZD, alongside a calcium channel blocker and an ACE inhibitor, is managing fluid balance through three separate chemical mechanisms simultaneously, each pulling in a direction the others did not account for. The combined fluid and pressure effects on an aging heart are not predictable from any single drug safety profile. They require the full picture to be assessed, and that full picture assessment is rarely performed in a standard 15-minute Medicare appointment. This is exactly the gap that costs people like Margaret their lives, not malice. Not negligence in the obvious sense, just a fragmented system where each specialist manages one piece without anyone reviewing the whole. Final drug, fifth. Proton pump inhibitors, omeprazole, pantoprazole, esomeprazole. These are the stomach protectors that 68% of adults over 60 take daily, often initially prescribed to protect the stomach lining from other medications on this very list. They are widely considered harmless. The research tells a more complicated story. Proton pump inhibitors work by suppressing stomach acid production. That acid, however, is not only for digestion. It is essential for absorbing magnesium, vitamin B12, iron, and calcium from the food you eat. When you suppress it consistently over months and years, you are creating progressive nutritional deficiencies in nutrients that your heart, your nervous system, and your blood vessels depend on to function correctly. Magnesium deficiency caused by long-term PPI use is particularly serious for cardiac patients because magnesium is involved in the electrical signaling that regulates your heartbeat. Studies examining PPI users who had taken the medication for more than a year found magnesium levels reduced substantially, enough to produce measurable changes in cardiac rhythm in vulnerable individuals. Margaret had been on omeprazole for 4 years. She reported occasional palpitations in the months before her death. Her doctors documented them, but attributed them to anxiety. Her magnesium levels had not been checked in over 2 years. If you have been on a proton pump inhibitor for more than 3 months without a review of your magnesium and B12 levels, that is a conversation worth having at your next appointment. The cost of checking those levels is minimal. The cost of not checking them can be something no medical insurance plan will ever fully cover. Now, I want to spend a moment on what I think is the most important concept in this entire video, and it is the reason Margaret died from a combination of medications that individually might have been manageable. Polypharmacy is the medical term for taking 5 or more medications simultaneously. In the United States, the majority of adults over 65 meet that definition. What the research consistently shows, and what rarely gets communicated clearly in a standard clinical setting, is that drug interactions do not add linearly, they compound. Each additional medication does not simply add its own risk to the pile. It multiplies the unpredictability of everything else in the pile. Margaret's 5 medications each had their own mechanism. Her statin was depleting her cardiac fuel. Her ACE inhibitor was accumulating potassium her kidneys could not clear. Her calcium channel blocker was triggering compensatory stress responses her heart was not equipped to sustain. Her PPI was creating nutritional deficiencies that disrupted her cardiac rhythm. And her diabetes medication was retaining fluid that increased the workload her already compromised heart had to manage every single day. No single doctor saw all 5 together. No single appointment was long enough to review the combined picture, and Margaret paid for that fragmentation with the rest of her life. If you are on multiple medications, and the last time anyone reviewed your complete list in the context of your current age, kidney function, and cardiac health was more than a year ago, please make that appointment. Bring every bottle to the table. Ask directly which ones have been reassessed for appropriateness given your age today versus when they were first prescribed. You deserve that review. Your Medicare or insurance plan covers it, and the few minutes it takes could be the most valuable appointment you attend this year. Please subscribe to this channel if you want to continue receiving information like this. I am committed to giving you the honest, research-based content that the standard healthcare system simply does not have time to deliver in a 12-minute appointment. Like this video if it has made you think differently about even one medication in your cabinet. And share it with someone you love over 60 who is taking multiple prescriptions and has never had a full medication review. Comment below right now and tell me, 1, if you are going to schedule a medication review after watching this, or 2, if you want me to go deeper into natural alternatives and cost-effective approaches to managing these conditions without the same combination risks. Your comments guide what I cover next. Margaret trusted the system completely. You now have information she never had. Use it to ask better questions, demand more complete reviews, and protect the heart that has been working for you every single day of your life. Everything shared in this video is based on published research and clinical experience. It is educational information, not personalized medical advice. Please do not stop or reduce any prescribed medication without consulting your doctor directly. These conversations are important. Have them with professional guidance.